in the retina where the hard exudates are. Otherwise, maybe you will not succeed to close the retinal break. But if it's created elsewhere, you might succeed in closing it. This patient was referred, as we were discussing before, that we have a lot of referrals from outside the country. You can see the tractional elements. There is tractional detachment, and I'm sure here I'm cutting it with the scissor. I am sure that tractional elements play a big role, or at least important role, in the development of retinal detachment in these cases. It is just exudation. There is element of traction in all these cases. My second case, 17 years old male, bilateral exudative retinal detachment. And as a complication, of course, those are very rare cases. The patient has no light perception in his right eye. And he was referred to me for the second eye. And at the beginning, I placed the buckle. This is debatable argument. In such cases, I like it. Maybe Carlos agrees with me. I have no idea. And you can see there is total retinal detachment. And you can see here, I find it also challenging to remove the posterior hyaloid. That means the tractional element plays a role in the development of this detachment. I'm not saying it is the only one, but it is one of the multiple factors that play a role in cause disease retinal detachment. And here I preferred, in this case, also to drain externally in order not to create retinal break that I might find difficulty in closing them. You can see here, I free the trocars from the vitreous, even keeping the lens in place. And peeling anteriorly is very delicate work. You can't leave tractional elements. And if you lose some, if you cannot remove everything, the buckle would do the rest of the job. Especially in this case, I decided to keep the patient faking. Even if I can go very anteriorly, but I rather to put a scleral band in such cases. You can see. Finally, this is the posterior hyaloid. It's almost completely shaved. And in this case, as you can see now, I did the laser under air in order to have a flat anterior retina, completely flat anterior retina. Completely flat anterior retina, because you can drain 100%. But once you have air, usually the anterior retina is flat. This is my third case, exudative retinal detachment in the left eye. Previous, I did him myself. Drainage with indirect laser and anti-VHF injection. And I think 3 weeks later, he developed a new retinal detachment. That's why I am for vitrectomy from day one in such cases. often my colleague, they argue with me why we don't just do cryo, drainage, cryo, and injecting some air inside the eye. I think you have better results in doing vitrectomy and releasing all the internal tractional elements inside the eye. Also, in this case, I placed a scleral band. You can see there is total retinal detachment. You have to be careful not to create a retinal break inside the eye. And you know, these cases are quite rare, at least in my practice. I don't do many of them. And you can see there is a lot of exudation underneath the retina. And here you can see the external drainage. No internal drainage, of course, in these cases as well. No internal drainage. And I tend to do a lot of laser treatment to the periphery in these cases, even areas where I'm not expecting to have cost changes. There was a retinal cyst. It means that the retinal detachment has been there for a very, very long time. And this is after the tamponade. And this is another case, I think my last case, 3-year-old boy, exudative retinal detachment in the left eye, no previous surgery. This is how the case looked like. In this case, I drained before I started the surgery. And instead of going through AC maintainer, I just inject through pars plana, and you can see the retina goes back partially. And you can the scleral band that I mentioned before, and I inject once again, drain once again, and finally, I have an access to the vitreous cavity. And here I'm detaching the posterior hyaloid, as all of us, from over the optic disc. And once I start doing these cases, I thought it was more difficult to detach the posterior hyaloid, but instead I found it, I mean, it's not very much difficult really to detach the posterior hyaloid in this age group. In this age group, I don't find it difficult. And once again, I drain from the same side, of course. That's why I try to keep it quite anteriorly, the drainage site anteriorly. I don't do other radial sclerotomy in order to drain. And you can see I'm quite anteriorly, very anteriorly, and I can reach very anterior retina without hitting the lens. And once again, as I explained before, heavy laser. So far, I did not do cryo. Maybe I should. I have no idea. And I complete my laser after air exchange. So I have a flat peripheral retina, and you use the tamponade that you feel comfortable with. In conclusion, vitrectomy with releasing of internal tractions is essential in the management of some exudative retinal detachments in cause disease. Thank you very much.
Thank you very much, Dr. Faisal. Very interesting cases. If we can have any question, Dr. Ahmed, for Dr. Faisal, please.
I can't hear. I'm not hearing.
Can you hear me now?
Yes. Excellent surgeries, Dr. Faisal, as usual. Perfect surgeon. We wish that we can see you, Dr. Ramzi, Dr. Carlos, and Dr. Faisal here, but it is very nice to see you across the screen. My question is, what type of tamponade at the end of the surgery do you use? Do you use silicone oil or gas?
Silicone oil. And usually in my regular cases, very often I use 1,000. In these cases, I use 5,000 centistocks because I try to keep it as long as possible. I don't consider it just as a tamponade. No, it is a space occupier because sometimes you have still some leakage from the course changes. And in this case, you keep well the space. I mean, once I'm sure that there is no more, all the retinal detachment disappeared completely, then I remove the silicone oil. So far, I have good results with this technique.
Okay, Dr. Nadeem, you have a question?
Yeah, wonderful videos, and thank you so much. I have two questions. The first question is that since you have drained it externally, did you ever think, just like you, when you do a ROP surgery, at the end of the surgery, if you put a bubble of gas inside, will that work? Because there is no internal.
Gas? What do you mean double gas?
Pardon?
You said double gas?
Yeah.
What is double gas? I have no idea, sorry.
Gas as a tamponade instead of silicone oil.
Yes. I understood. But, you might use it. You might use some of my Turkish friends, they use air, but really I'm for long-acting space occupier place in these cases. I have no idea why. I feel comfortable with it. And it lasts as long as I wish. It lasts as long as I wish. That's the reason.
My second question that I see your video has clearly demonstrated the role of abnormal posterior vitreous in Coats disease or any exudative retinopathy in children. So I see that you have never used triamcinolone in your cases. You are an extremely skilled surgeon, so probably you're not using. Do you have any advice or tips for young surgeons when if they go in and not that bad cases, but especially in exudative Coats diseases?
Well, thank you for the compliment, but I use it. I think in these cases, and I use it and I showed it. I mean, it was floating over the heavy liquids. I use it at any, it's not necessary that you use it at the beginning. You can use it at any step of surgery.
I ask a question.
Thank you very much. There is any question, Dr.
Yeah, maybe I can just make a comment and question for Faisal. So these are really great surgery, Faisal, but in my practice, I usually really hesitate to go into the vitreous if the patient is young, like less than 3 years old, 4 years old, because of creating a retinal break. It's really very, very big problem for the children. And therefore, if there is no traction, if there's only bulbous retinal detachment, I do not want to go inside of the eye in such patient. The other things in Coats disease, again, laser treatment is usually not enough to occlude all these telangiectatic vessels. And in most patients, I also prefer cryo, external cryo, to ablate all these vessels, especially in thick retina. So in your patient that you apply laser, that patient was enough to ablate all this retina. It was okay. What do you think about these ablation methods?
Yeah, first, Ramsey, first, I mean, the first comment of your question, I agree. I said not in all cases, in some of cause disease retinal detachment, I think vitrectomy is essential to repair the retinal detachment. I agree, not in all cases, but in cases that I presented, I think there was no place. I mean, you can't fix the retina without doing vitrectomy and removing all the internal traction. The second part of your question, you are right, but I said I use heavy laser, confluent laser and heavy laser. And I finish my laser under air in order to make sure that I did. But I said you might be right that I should consider cryo in the future.
Yeah,
It is easier, it's faster, and is very effective, especially if you don't have retinal breaks. It's very effective. You don't have retinal breaks.
Therefore, I'm asking because I don't have experience with heavy laser, only heavy laser. So this patient was really good. And later on, did they need any ablations or was enough the heavy laser? So I have no experience with under air.
No, they are okay. So far, they are okay. So far, they are okay.
Okay, good.
Okay, thank you very much.
I said I try to keep the internal tamponade as far as I think that is necessary to keep. That's why I use silicone oil.
Great, thank you.
Thank you very much, Dr. Faisal. Thank you, Dr. Ramzi. I think now we move to Dr. Ramzi. And Dr. Ramzi, actually, he will talk about the influence of crescent-shaped selective internal limiting membrane staining in terms of dye toxicity in temporal inverted flap techniques. Very big names, and Dr. Ramzi now he will clarify these all things. Yes, Dr. Ramzi.
Thank you, Mohammed. So, dear moderators and dear colleague, in my talk, we'll speak about, as Mohammed told, the spatial new selective ILM.
Your voice, Dr. Ramzi, little bit increase the voice, so to be more clear for the audience.
Is it okay now?
Yes, now it's okay.
Okay. We'll speak about this new selective ILM staining technique to eliminate dye toxicity in temporal inverted flap technique. These are my financial disclosure, but none of them related with the content of this presentation. As you know, ILM inverted flap technique is first described by Michalewski et al. 10 years ago. In this first technique, they apply 360 ILM peeling and they invert ILM over macular hole area as a multi-layer fashion from all directions. And we call this technique as classic multi-layer ILM flap technique. Then different modification is published, such as insertion in this technique. ILM is inserted into the macular hole to increase anatomical recovery, anatomical success rate, but this was not good for functional recovery. And later on, a single layer inverted technique developed from different directions, such as temporal, inferior, superior flap, pedicle flap, and temporal flap became more popular in this technique. So single layer inverted flap technique, especially temporal inverted flap technique, we preserve nasal part of ILM, and therefore we may avoid any iatrogenic injury on the papillomacular bundle. Also, the ILM flap creates a breach, natural breach between the edge of the holes. Also, it provides vitreous-free medium for glial proliferation and regeneration of retinal structure underneath, and improve anatomical and functional results. We publish our comparative results with conventional ILM peeling and temporal inverted flap technique in large macular hole, and we report a superior anatomical and functional result with temporal inverted flap technique. We also evaluate post-op configuration of ILM flap with emphasized OCT, mode of OCT, and geography. I think this is the best technique to show the ILM configuration after surgery, flap configuration. As you see, in most population, we observe single layer inversion of the flap as a smooth surface. And in adult group, we observe wrinkling of ILM flap, with, especially in patients with mild epiretinal proliferation. And in rare patients, we observe folded flap. And in our series, in only 1 out of 23 eyes we observed folded flap. In this patient, we couldn't manage to invert flap as a single layers. And in all patients, the ILM flap was completely covered the macular hole area. So as you know, however, we have toxicity problem with vital dyes, and they have been reported the vital dyes may affect functionality of the photoreceptors, RP and ganglion cells, even after application lasting less than 1 minute, 2 minutes. Besides this, in inverted flap technique, the stain ILM remains on the macular area, causing long-term contact of dye with retinal tissue with RP. And we know there are many studies with ICG dye toxicity, but a few studies with Brilliant Blue and Jindal et al. Reported 3 cases with macular toxicity following Brilliant Blue assisted macular hole surgery, and they reported foveal thinning, macular hyperpigmentation at the level of RP and limited visual outcome despite closure of macular hole. And to eliminate this problem, Scapula et al. Introduced the use of PFCL bubble to reduce the risk of contact RP cells with injected dye. In our crescent shape staining technique, we aim to eliminate dye toxicity in contact with RP and photoreceptors, which remain trapped on the inner surface of inverted ILM flap for a long time. And we evaluate the comparative results of 2 techniques with conventional staining and selective staining technique in terms of macular function and morphology, and publish our results in Turns Eye Research Journal very recently. So in this study, we applied 27 gauge. In all cases, we used Brilliant Blue to stain the ILM flap, and all temporal inverted flap, and 8% C8 gas tamponades. And ophthalmic examination and evaluation included best corrected visual acuity, indirect ophthalmoscopy, SDOCT, and also we apply amphimetophosis angiography to define flap configuration of microperimetry. In 2 groups, and for conventional ILM staining groups, we inject small bubble of PFCL over the macular hole, just to close the macular hole, then stain all around the macular hole ILM. In this crescent shape ILM staining group, we inject a large bubble of PFCL. We only stain the crescent shape, temporal crescent area where we will start the ILM peeling. And this is a pair of pictures of the 2 groups. And in the first surgery, as I mentioned, a small bubble of PFCL over the macular hole area, then inject Brilliant Blue, and keep there at about 30 seconds. And during injection and aspiration, we close the infusion to reduce or to eliminate turbulence. As you see, all the surface of ILM is stained, and after temporal crescent, we invert, but ILM flap at the inner surface, ILM flap is covered the macular hole area, it is stained, and the dye trapped over the macular hole area stay there for a long time. However, in new technique, we inject a large bubble of PFCL. So I think it's not running. Yeah, large bubble of PFCL, only stain the temporal crescent area, and not to macular around the macular hole area. As you see in this technique, only the temporal crescent area is stained, then invert ILM flap in the same fashion, but the inner surfaces of inverted flap is free of dye. This is before and 3 weeks after surgery of the second case on the video. As you see, it's perfectly good macular configuration. We can observe ellipses on the external limiting membrane. Also, we define the ILM flap configuration with OCT angiography. As you see, smooth single layer inversion of the flap. And we define potential dye toxicity as limited improvement in visual function, cystoid change in neurosensory retina, subfoveal focal RP alteration, and disruption of macular morphology and ellipsoid zone. The basic characteristics of the 2 groups was similar, and the minimum macular diameter was about over 500 micron, and ellipsoid defect diameter was over 1000 micron, but there was no significant difference. And in all eyes, ILM flap is covering the whole area completely. And in most of the patients, we observe smooth or wrinkled flap as a single layer, but only in 1 eye, each group, we observe folded flaps. So the closure rate was 100% in old group, and best corrected visual acuity was similar. There was no significant difference. And also microperimetric result was similar. And ellipsoid defect diameter was slightly better, smaller in selective staining group, but there is no significant difference between the 2 groups. However, we observe focal area of RP atrophy in 3 out of 16 eyes in conventional staining group, and cystoid macular edema and another 3 out of 16 eyes in the same group. And we did not observe this complication in selective staining group. This is one of the patients. This is before, 1 month after surgery. As you can see, perfect macular congregation. But in 3 months after surgery, small cystic change start around the macular area, and this increased during at the month 6. Another patient before and 1 month after surgery, again 3 months after surgery, we observed cystic change on the nasal part of the macular hole, macular area, and this increased at month 6. This is another patient. This patient we observed flat open closing after surgery, but 6 months after surgery, we observed significant cystic change, which is even elevate the ILM flap or the macular hole area. So, Retinal reported their comparative results with conventional and selective ILM staining technique, and they apply insertion technique, not inverted flap technique, and they reported significantly better visual acuity and smaller ellipsoid zone defect size in selective staining group. So in conclusion, temporal inverted flap is a novel technique associated with improved anatomical and surgical results, especially in complicated macular hole cases. However, long-term contact of the stained ILM with the neurosensory retina and RP might cause toxic effect. And even in this problem is relatively in large macular holes, maybe at high risk for toxicity. And therefore, the crescent-shaped selective staining seems to be safe and effective in inverted ILM flap technique, but we need further randomized control studies to determine the impact of this technique. Thank you for your attention.
Thank you very much, Dr. Ramzi. Very interesting and excellent presentation. We'll have 2 minutes for discussion also. Dr. Ahmed, please, if you have a question for Dr. Ramzi. Also, if Dr. Fayyad and Dr. Carlos, they can join us for this discussion.
Thanks a lot, Dr. Ramzi. Excellent presentation, excellent videos, and very good technique. But I want just to clarify, are you using ICG as a stain or the BBG? Because the ICG, we all know definitely the toxicity, but the BBG, the level of toxicity is much less. So maybe that's why there was no much of a difference in the best corrected visual acuity post-surgery in the different groups. Any further explanation about this point?
Yeah, I agree with you about ICG dye, but I don't use ICG dye for almost more than 10 years, last 10 years, because we can reach the brilliant blue. As you know, the brilliant blue is less toxic, and there are a few studies on literature which show the toxicity of brilliant blue. But in this technique, in inverted flap technique, we trap a large amount of dye over the macular hole area and stay there for a long period of time with long contact with RP and sensory retina. And therefore, maybe a standard ILM peeling and removing technique, conventional ILM peeling technique, it's not problem, because in this technique, we remove almost all stained ILM from the eye. But in inverted flap technique, we trap dye in the macular hole area. And therefore, even if brilliant blue looks less toxic or there is no toxicity, but with this technique, we can observe some toxicity problems. And we can see this complication maybe when this technique is improve or the number of cases increase, and also for the follow-up time increase. And therefore, we needed to create this new technique to eliminate this toxicity.
My point is that the ILM, the inverted ILM part, is not in direct contact with the RPE. It is actually a scaffold for the retinal layers just to close this macular hole. Maybe Dr. Carlos has a point to share as well in this discussion.
I congratulate Ramzi. The problem for me is that, to say that 6 months later, one of your cases is related to the dye, for me is too much, because, at the end, if you put gas, I use SF6, for example, I have gas less time than you. And, at 10 days, the macular hole is, or the macular hole closure is free, and you cannot see the dye. Then, to say that this macular edema is related to the eye, it may be, Ramsey. I don't know it, but there are a lot of papers saying that brilliant blue. Although I commented to you that I had one case, but many papers saying that brilliant blue is not toxic, and some of them.
Put it.
Excuse me. Oh, wow. Everything went blue.
You can continue, Carlos.
Everything went blue. Okay, then I'm not sure that brilliant blue. I agree with it. It's in green, even in triple blue. But brilliant blue 6 months later, I don't know, Ramsey, but I congratulate the technique. It's wonderful.
Carlos, I agree with you. I'm not sure either about the toxicity of brilliant blue. And maybe this cystic change is not related with toxicity. We don't know, because there's a few cases, small case number of study. But this is the explanation in our papers, that there is no other reason to see this late cystic change in the macular hole area. And we did not see this cystic change in conventional ILM staining and peeling technique. And therefore, we assume that it's because of toxicity, but we are not sure either. And even it's not less toxic, this technique, I think, will be good for surgeon who use still ICG dye in American guys.
Thank you very much, Dr. Ramzi. If there is a last comment from Dr. Faisal before we close the session.
Thank you, Ramzi. Very interesting technique. I use it sometimes. It's very nice. I like the multi-layer technique. I think I don't have to use long-acting gases, and I think the hole closes within, I think, a few days. You mentioned, what about the vision? What's your explanation with the temporal flap technique? You have a better vision. You mentioned that, but I would like to hear it once again, so we can understand the importance of the temporal flap technique comparing than peeling all the ILM all around.
Okay, thank you, Faisal. And we recently published 3 studies related with this inverted flap technique. One is the comparison of standard classic ILM peeling and temporal inverted technique, and we found that the functional results, both anatomic and functional result, is significantly better with temporal inverted technique. And especially the macular morphology was the U shape. We call this U shape, V shape, or W shape irregular macular configuration. In most of the patients with a single layer inverted flap technique, we observe U-shaped macular configuration, means normal macular configuration. And I think a single layer inversion is important. Why? Because the insertion technique, when we insert ILM into the eye or in multi-layer ILM flap, ILM is go into the eye, into the macular hole area. And this ILM may prevent good macular morphologic healings on the macular hole area. And therefore, single layer inversion, I think, is better than multi-layer inversion or insertion technique for functional and both anatomic results. This is my experience.
Thank you very much for Dr. Ramzi, and thank you, Dr. Carlos, Dr. Faisal also for a very nice webinars and sessions. I think we are having now a buyer symposium in the same sessions. So I will give the mic for Dr. Avinash and Dr. Madhav Rao. So you can stay also with us, Dr. Carlos and Dr. Faisal, Dr. Ramzi. Thank you.
Thanks.
Thank you. Good evening and welcome to the buyer symposium. This will be a talk show between Dr. Madhav Rao and myself. And we just thought, we would get an opinion, just an informal talk show about some topics that we deal with on a regular basis. Dr. Madhav Rao, of course, is a very well-known vitreoretinal surgeon, and he works at the Burjeel Hospital in Abu Dhabi. And it will be a delight for us to have a discussion together. So, Dr. Madhav?
Yeah, good evening, Dr. Avinash, and good evening, all great speakers. We heard your talk. It was excellent retina session, surgical retina session. Well, I'll be sharing a podium with Dr. Avinash, who is a consultant ophthalmologist. He's a chief of retina at Moorfields Eye Hospital, UAE. So I'm going to ask a few questions. It will be an informal talk show, as Dr. Avinash said. I want to know his experience. I know he's got a vast experience on management of diabetic macular edemas in the last 15 years or so. So I want to know how he would proceed with his treatment of diabetic macular edema, whether it's going to be intensive in the beginning. What about his loading dose? How about after the loading dose, whether he would continue with PRN or a treat and extend? So I would just like to know whether he would mirror his practice on basis of RCTs.
Thank you, Dr. Madhav. That's a very interesting question. And, you know, we've always been told that the best results, as you know, come from the clinical trials where there is intensive treatment. But, you know, we've all seen with our patients, especially in this region, that it's not very practical to have an intensive monthly treatment. And so I think what we need to do is really extrapolate the data from the clinical trials and try and see how we can use the clinical trial data to ensure that the patients get the best result from their treatment. So what is the strategy that I use to give them the maximum benefit? Well, you see from the VIVID and VISTA data that patients, they continue to show improvement after the 5 loading doses. So the 60% improved after the first dose, and then that kept on increasing, and more patients were added to that improvement group after the 5 loading doses, and that's by which time the maximum gain was achieved. So I try and encourage the patients to have that 5 loading doses, at least 3 loading doses, and you want to get them into one of these groups, and so that's what I try and do, and so they can get the maximum benefit what we learned from the clinical trial. So we can confidently say to the patient group, and that's quite palatable for our patients, and the as we've seen that the amount of the macular edema, it continues to decrease, even though that the treatment is less with the with aflibercept compared to ranibizumab in this protocol T group, as you can see by this slide. So I give them the loading dose, and then it's a treat and extend PRN combination, I would say. And we've seen also from the FRB registry that patients who had a lower vision to start with had a better outcome when they were on aflibercept compared to ranibizumab over the first 12 months, the 12 months of the FRB study. So so that's how I counsel these patients. And then the median number of injections, I tell them in this group was 8 compared to 6 in the ranibizumab. So slightly more injections in the aflibercept group here. But what I can tell them is that with a good loading dose, we can then switch to a as needed extended treatment regimen. And that seems to be what's most palatable to the patients practically for their diabetic macular edema. But, Madhav, how do you see the guidelines? And, we work together on guidelines for ESO. How do you see that this sort of data, the guidelines, do they mirror this sort of data?
Well, as you pointed out on the guidelines, we would certainly follow our American Academy of Ophthalmology or the European Society of Retina Specialists, EURETINA guidelines. And we also have follow the Asian expert guidelines and the local guidelines, which we all of us sat together and formulated. Now, talking about the EURETINA guidelines, it is said to be antivascular endothelial growth factor therapy has emerged as a first-line therapy. And no more the lasers are recommended for a central involving diabetic macular edema. Aflibercept seems to is the drug of choice in diabetic macular edemas with baseline below the 69 letters. And it shows superiority to other two anti-VEGFs in the first year of treatment. The next slide, please. Same thing was reflected in Asian expert guidelines. Anti-VEGF therapy should be given as a first-line treatment for patients with central involving diabetic macular edema with central visual loss. In patients with worse vision, 612 or 20/40 and less, aflibercept may result in a more rapid visual acuity improvement than the other two drugs at first year, though there is not much of difference or no statistical significance at the end of 2 years, according to DRCR NET Protocol 3 study. In patients with a better visual acuity, 612 or better, all three anti-VEGFs, aflibercept, ranibizumab, and bevacizumab, are equally effective. And patients with diabetic macular edema, as we discussed in the first slide, probably we need an early intensive treatment with at least 5 to 6 injections, so as a loading dose, totaling as many as 8 to 9 injections in the first year, which probably could give a very good result, and probably would reduce the treatment burden in the subsequent year, probably 5 to 6 injections in the second year and 2 to 3 injections in the third year. Now, we also have formulated the local guidelines under the umbrella of Emirates Society of Ophthalmology. We prepared the ESO consensus of diabetic macular edema. In fact, it was a very good exercise. We had to answer so many questions on which is shown on the right side. We were almost like 15 retina specialists in SEHA and institutions, as well as in private hospitals of UAE. We had a medical writer all throughout the discussions. In fact, we had almost like 8 to 10 meetings for a period of 1 year. And we also created an algorithm, which is very good. I mean, for someone who is a general practitioner who is showing a lot of interest in treating diabetic macular edema, he has got an easy algorithm to follow to choose the management plan. And in fact, a couple of months back, ESO published it, and we had 90 references, which is very incredible. And this can also be used at insurances for approval purposes. And the ESO has circulated to all the SEHA institutions and to other hospitals, whereas Bayer has circulated this in private practices. Those who are interested, probably at quick conference, they can pick up these brochures from the Bayer medical booth. And what I would suggest is we had a fantastic answering discussion all during the process. Can I go to the next slide, please?
We had many agreements and disagreements till we got to a consensus.
Of course. Especially, I remember treating in special circumstances, bilateral injections, and the injection room standardization protocols.
Yeah, it was a very enthralling experience, but also very rewarding and satisfying when we could come up with such robust guidelines. And I think this is one of the first local guidelines that have been published. So I expect that in Europe, they will be quoting our guidelines like we are quoting the EURETINA guidelines. What do you think?
Absolutely fantastic, incredible experience. And yeah. So coming back to or shifting our gaze towards the other disease, retinal disease, wet AMD. What's your preferred approach in treating exudative AMD patients?
So, wet AMD, many people say to us that, oh, in UAE, we don't see much wet AMD, but actually we do. And, there are plenty of older people in the UAE. People prefer to stay. There are, yes, the local population, but also the expat population. And also now I have seen that a lot of patients who were also getting treatment outside the country have been stuck and have been coming, out of the woodwork almost for their AMD treatment because they are here because they cannot travel because of COVID. So I have a very straightforward technique for treating AMD, and that's treat and extend. I mean, there is no doubt that treat and extend is the way to go. I mean, about 2012, when I did my fellowship in Sydney with Mark Gillies, he was doing treat and extend at that time. And that was my first exposure to it. And I saw the huge difference between treat and extend and PRN. And I switched from there and I moved to Dubai in 2013. And since then, I've been doing treat and extend. And so treat and extend, basically, I give the patients a loading dose of 3 to 5 injections. And then once they are stabilized, I will extend them at a 2-weekly adjustment. So once they're stable after the loading dose, I will move them along. Every 2 weeks, I will treat them, even if the OCT is dry, and then extend it. Again by 2 weeks. I've managed to get patients up to 16 weeks, and there are several patients who are on 16-week injections. Of course, there are some patients on 8-weekly, 10-weekly, 12-weekly, 14 or 16, and that was also reflected, in Altair, which showed that up to 60% of the patients were maintained at 12 weeks or beyond. And in fact, 40% of the patients more than 40% were on 16-week injections. And so I use this algorithm also, or this treatment method very simply, and you don't really have to think too hard. If the patient shows activity, then I just dial it back by 2 weeks. And, so if a 10-week patient was to show some activity, then I would bring them back at 8 weeks. So, Altair gives us that confidence. You can say to the patient that, by doing this, we can get you at least half chance that you can get to 16 weeks, but more than 50% chance that you will get to every 12 weeks. And the adjustment in this was, 2-weekly or 4-weekly. So I use the 2-weekly adjustment, which seems to work in these patients. Another controversial topic, Madhav, when we've had this discussion quite a lot of times, and with it's been a topical thing, is as I was saying, that the patient, I extend them when they are dry, and I dial it back when there's fluid. So, what is your strategy of treating this fluid, and how do you view fluid? I mean, are you as strict as I am when I say, if there's fluid, I will dial them back. If there's no fluid, I'll extend them. How do you handle fluid?
Well, first of all, answering your question on the treat and extend, I think it's a good strategy to load them with 3 to 5 injections, and then extend them, as you rightly said, every 2 weekly, and see them, because not every disease follows the same curve, especially with the wet AMD. And, it's a disease of infinity. We don't know when we are going to end with the injections. So it is always good to carry them on. And if there is a disease activity, obviously to come back 2 steps back by 2 weeks. Coming to the fluid, handling of fluid, it's a very interesting debate which has creeped up in the last couple of, probably a year or so, on the amount of fluid. When do you consider it as an activity? When do you consider it as inactive or a stable fluid? There's a terminology called a stable fluid. Now, all this is possible probably because of the multimodal imaging techniques we have now. We also look at not just the structural OCT, SSOCTs, we also look at the OCTAs and come to the conclusion whether it is there is a fresh fluid or a disease activity. Next slide, please. So for which we need to understand the fluid in different compartments. Now, it could be a intraretinal fluid, IRF, or it could be a subretinal fluid or a sub-RPE fluid. Now, as we all understand and know, probably IRF is typically associated with worse vision at the baseline and at any point of time compared with a subretinal fluid or a sub-RPE fluid. Now, subretinal fluid per se, in the absence of intraretinal fluid, is typically associated with a better vision at the baseline if there is no associated intraretinal fluid. And over a period of time, with the IRS or subretinal fluid, and is associated with the adverse visual acuity when it is residual. Next slide, please. Now, this was shown in a view post hoc analysis. Eyes with early persistent intraretinal fluid were shown to have a significantly worse vision gains than those without. You can see it on the left-hand side. The IRF definitely had less visual acuity in patients with or without IRF all through week 52 as compared to subretinal fluid on the right side. The next slide, please. The same thing was conveyed through Altair post hoc analysis. The foveal intraretinal fluid was associated with worse visual acuity than being no intraretinal fluid. A residual SRF was tolerated without affecting the visual acuity. The mean absolute best corrected visual acuity in patients with no RF, non-foveal IRF and foveal IRF through week 96 showed a worse visual gains as compared to subretinal fluids, either foveal or non-foveal. Next slide, please. The CAT post hoc analysis also showed intraretinal fluid shows a negative association with visual outcomes as compared to the subretinal fluid. So in general, I would say we wouldn't tolerate intraretinal fluid as against a subretinal fluid. Especially to say, probably in the first year, I would be more intense, even I would treat probably a subretinal fluid. Possibly in the second and the third year, if there is a minimal subretinal fluid, which is probably like a chronic CSR, probably which is not detrimental to your visual acuity. In summary,
yeah, that was a good. I liked one point that you said, which was fresh fluid.
Yes.
So you know, and that's how we measure disease activity, I guess, is the appearance of fresh fluid. Now it's nice to see that the patients with the the subretinal fluid did not affect the visual acuity, and so that is reassuring that in some, as we all see some patients with this persistent subretinal fluid, which doesn't seem to go, but as long as the vision is maintained, then we know that that is not harming the patient. Whereas we know that the appearance of fresh fluid or fresh intraretinal fluid especially, that is an indicator of activity, and that's the one we should really go after.
Absolutely.
So I think that's a great point that you make. So the fresh fluid is the great
fresh
word.
Fluid,
that,
yes.
So
I mean, in summary, it's anti-VEGF therapy is recommended as a first-line therapy in central involving diabetic macular edema, while aflibercept is the preferred choice in eyes with best corrected visual acuity or a letter score less than 69 letters.
We also said that we also said that early intensive treatment in year 1 gives rapid and increasing vision gain, and delaying treatment may lead to irreversible vision loss in DME, and vision gains after the intensive treatment can be maintained with a reduced treatment burden in year 2 and beyond.
In Altair, up to 60% of patients were maintained at an interval of more than 12 weeks, and more than 40% of the patients were maintained at interval of 16 weeks by week 96. Studies highlighted the suitability of aflibercept for a proactive treat and extend regimen with extended treatment intervals in year 1 and beyond. That's a very valid point. More than 60% beyond 12 weeks and 40% beyond 16 weeks.
And also, as Madhav pointed out, that the evidence shows that intraretinal fluid has a detrimental effect on the visual outcome, whereas some stable subretinal fluid, if there's no intraretinal fluid, did not seem to adversely affect the visual outcome. So that is reassuring as well. So that's quite interesting topic that we managed to get through. I don't know if anybody in the audience or anybody on the panel has any questions for us.
Yes, any question, please? Okay, in the end of this session, I'd like to thank Dr. Avinash and Dr. Madaurav for this value session. And thank you for Bayer also for their support in this session. Thank you very much. And we will see you, inshallah.
Thank you, ma'am.
Okay, thank you. And we'll come back in 10 to 6 again to our hall to resume our lectures. Thank you very much.